and we're grateful to have them as a partner in our educational efforts. Thank you. In addition to establishing this lecture series, the Niarchos Foundation supports our Teacher Scholar program, which enables us to engage high school and middle school teachers in bringing the excitement of neuroscience into their classrooms. And I think if you put your hands up, there are members of these Teacher Scholar program all around. And so welcome and thank you. And just join me in thanking the Niarchos Foundation for their generous support of the Mind-Brain Behavior Institute. It's an exciting time for Columbia University, the Zuckerman Institute, and for brain science. For those of you who may be unfamiliar with the missions of the Zuckerman Institute, we bring together an extraordinary group of scientists, some 60 independent laboratories, in a state-of-the-art facility, the Jerome L. Green Science Center, to transform our understanding of brain and mind. We've been recognized philanthropically by Mort Zuckerman, the Jerome L. Green Foundation, and the Niarchos Foundation, providing support that furthers our goals. But of course, there's always work to be done, and I invite all of you to be our partners in discovery. We appreciate your consideration in supporting the good work of the Zuckerman Institute through our Friends Fund. And now it's my very special pleasure to be able to introduce Sydney Hankerson to you this evening. Sydney is an assistant professor in clinical psychiatry at Columbia University Medical Center, and he's one of the two founders and organizers of the Zuckerman Institute Wellness Center, a joint neurology psychiatry effort to introduce clinical imperatives in brain science to the local Manhattanville community. Sydney grew up in Fredericksburg, Virginia. His father was a church deacon, and I think this may have influenced his faith-based approach to psychiatry through the establishment of close links with the Harlem community and its churches. Sydney specializes in issues related to major depression, the impact of clinical diagnosis and faith. And he brings the sophistication into discussions of racial correlates and poverty in signs of depression. And amongst other premises, he argues that mental, physical, and spiritual health are indivisible elements in the discussion about depression. And he's also a strong advocate of initiating treatment early. So please join me in welcoming Sydney, whose talk is entitled Confronting Mental Health Disparities with Community Partnerships, Writing a New Story Together. Sydney, come and join us.
Thank you, Tom, for that extremely generous and warm introduction. It's certainly humbling and exciting to be a part of this exciting initiative with the Zuckerman Institute. However, the most exciting thing that's happened to me recently is that 1 month ago, I celebrated my 1-year wedding anniversary with my wife, Khadijah. She couldn't be here this evening, but I wanted to give her a shout out publicly. So good evening, everyone. I said good evening, everyone. Good evening. All right. In the spirit and tradition of the African American churches with whom I partner, I thought we'd start with a little call and response to set the tone for tonight's lecture. I'd first like to thank the Niarchos Foundation for your extremely generous support and your philanthropic donations for making Columbia faculty to have a platform for sharing our research with the community. Thank you. I'd also like to thank Mr. Giancarlo Biangira, who is Executive Director of the Zuckerman Institute and who has been a relentless advocate in making sure that our transition to the Wellness Center has gone off smoothly. I'd like to thank Dr. Myrna Wiseman, my research mentor and supervisor, who has been a relentless advocate and mentor for me over 8 years at Columbia. And I thank my staff, Dr. Faith Miller-Satie and Ms. Emily Santiago, for you all's tireless efforts and all the volunteers that have contributed to our work. Most importantly, I thank you all, the community, for coming out on an overcast Monday to hear about how we can write a new story together in forming community partnerships. I'd like to first start with an icebreaker. So if you could please turn to your neighbor and share the story of your name. Who named you? What's the meaning of your name? And how your culture influenced the history and meaning of your name. So each person spends about 30 seconds doing this and then switch. You can begin. So about 15 more seconds. About 15 more seconds and we're going to wrap it up. All right, everyone, if we could bring it back together. All right, excellent. Thank you for your participation. I saw a lot of smiles, a lot of giggles. So hopefully you know a little bit more about your neighbor than you did when you first came in today. But the purpose of that exercise is really to help illustrate how our history follows us and our name has meaning, whether or not we consciously think about it or not. During our time together, I'm going to paint a picture and my vision of how we as a community can rewrite the story of psychiatry and mental health that's taken place between Columbia University and the village of Harlem. I've broken my talk into 3 sections. We'll first talk about major depression and racial disparities in mental health treatment, and then walk through my research focused on testing the feasibility of partnering with churches to provide mental health care. And lastly, I'll encourage you to think about what each of you can do. What is your unique role in rewriting this story? So major depression is now the #1 cause of disability in the world, as recently reported by the World Health Organization. This means that more people in the world suffer in terms of their functioning and their quality of life and miss days from work from depression than any other medical condition. And while depression is certainly devastating for anyone who is diagnosed with it, for African Americans with depression, it's particularly devastating. This data is from over 3,500 individuals who took part in a national survey. And people who had been diagnosed with depression over the last year were asked how depression impacted their work, their relationships, and their social life. and African Americans compared to white Americans suffered more. Black adults with depression had more severe impairment in overall functioning in their social life, relationships, and at work. Now you would think, given how disabling depression is, especially in the African American community, that people would be running to my office for treatment. Unfortunately, we know that's not the case. I began my journey at looking at disparities by looking at an even larger national survey that involved over 24,000 white and 8,200 black adults in the United States. And of those who had depression, we found significant racial disparities or racial differences in treatment. Black adults who were depressed were significantly less likely, by nearly half, to receive any type of treatment. Whereas black adults who were depressed were nearly 2 times as likely to be hospitalized. This difference, the overuse of hospitals as a source of care, indicates the need and a gap in which we could try to investigate, and led me to the question of what causes these disparities. I'm so glad you asked. While there are many factors that contribute to disparities in care, stigma is a universal factor. And as a way to illustrate how stigma operates, I'd like you all to just shout out, when you hear the words mental illness or depression or even psychiatrist, what comes to mind? Crazy. I heard the C word, schizophrenia. What else? Bipolar. Sadness. Sad. Isolation. Unstable. Anxiety. Hallucination. Unpredictability. Couple more. Loneliness and death. Wow. Fear and suicide. Unemployment. I said a couple more, but you all keep coming. So are any of these words positive? No. This is how stigma operates. Stigma contributes to fear and shame of people acknowledging the fact that they may have a mental health problem. And it keeps many people suffering in silence and prevents people from seeking help. In addition to stigma, in particular in the African American community, there's a history of systematic racism and injustices that have been inflicted by medical professionals and those people who are supposed to help communities of color. This is a picture of the infamous 1932 to 72 Tuskegee Study of syphilis in an African American male. During this federally funded study, researchers in rural Alabama told over 300 black men who were infected with syphilis that they were getting free treatment, when in fact, no treatment was given. And in 1942, when penicillin was recognized as the treatment for syphilis, it was intentionally withheld so the researchers could identify how syphilis impacted the body. This instance, and many others that we've seen throughout history, create a culture of distrust for researchers and medical providers that we're confronted with, and it contributes to disparities. And I'm sad to say that this distrust is alive and well in Harlem today. I've heard many community members approach me and tell me that they hear that even the wonderful work that is being conducted at the Zuckerman Institute is intended to harm children of color. Now, of course, that's not true, but there's a great deal of distrust with researchers and with medical professionals in the African American community that also contributes to disparities. And then when someone finally gets the nerve to actually go seek help and get treatment, lack of access or not having a provider that you can go to see is another cause of disparities. It can often take 3 or 4 months just to get an initial appointment at community mental health clinics. So these are just some of the factors that contribute to disparities, in addition to educational and income inequalities. So given this, I began to look at why is it that African Americans and Mexican Americans now have the lowest rates of depression treatment in the country. And the reason has in large part to do with the disparities that we mentioned before. And one of the tragic consequences of untreated depression is suicide, which someone mentioned earlier. Suicide is actually a symptom of depression. And for the first time in our nation's history, African American boys between the ages of 5 to 11 years old have higher rates of suicide than white boys. And so depression and suicide is no longer an issue that folks in the African American community can ignore. So to deal with that, where's the good news? To deal with that, I began under Dr. Wiseman's mentorship to look for alternative pathways for engaging people in mental health treatment. Instead of utilizing traditional mental health services, we tried to find alternative pathways. And an extensive literature review and personal experiences led us to clergy. Evidence shows that throughout the United States, people who have emotional problems are highly likely to first contact a clergy person. In fact, clergy are more likely to be contacted with people who have emotional problems than psychiatrists or general physicians. So clergy are indeed frontline mental health professionals who provide a great deal of counseling and referrals to mental health services. And faith-based interventions hold great promise for African Americans in particular, who by all accounts are the most religious group of individuals in the United States. 87% of African Americans belong to at least one religious group. 79% say that religion is important, and 53% attend church at least once a week. Tom mentioned that my dad is a deacon, but I'd also like to add that my mother, growing up, played the piano for the little kids choir. So this 53% of attending church a week for me was more like 4 or 5 times a week. But church provides more than just a place for people to go to talk about spiritual guidance and support. It also can be like a second family. One of my fondest memories when I was 10 years old, it was 1988, New Year's Day, the first day of the year. It was a beautiful, sunny, brisk day in Fredericksburg, Virginia. And it was a day that I took my first communion. Both of my grandparents came up on my mother's side. And as I took communion that day, it was like everybody in the church, just like I'm looking at you now, everybody in their church, it was like they wrapped their arms around me with an embrace of warmth and love and connection. And that is what churches can provide. And churches have a long history, in addition to that, of providing medical, educational, and socioeconomic resources for community members. Importantly, Columbia has a storied history of partnering with a church in Harlem to provide mental health services. This is a picture of Dr. Elizabeth Bishop Davis. In this picture, she was actually a student at Barnard University, but she graduated from the College of Physicians and Surgeons in 1949. In her first year of medical school at Columbia, she actually served as a clerk in the LaForge Clinic. This was the first mental health clinic dedicated to providing free mental health services to African Americans in Harlem. And her father was pastor of the church. And the services were provided in the basement of St. Philip's Episcopal Church, right on 134th Street and 7th Avenue. So a part of the story of Columbia and Harlem is providing mental health services through a faith-based institution. So over the last several years, I've been obsessed with trying to answer the question scientifically, is it feasible to provide church-based mental health care? The first step that we did in looking at that question was to learn what pastors wanted and needed. So we conducted interviews and we did focus groups. We brought groups of pastors together, provided food, and just let people talk about some of the issues that they see as it relates to mental health in African Americans in their congregations. And one of the key themes that arose from those interviews and talks was that stigma is indeed a huge barrier. One pastor said, as African Americans, we just never get help. We think that counseling isn't for us. The notion that somehow, African Americans can't seek mental health care. So stigma was a huge barrier. Another key theme that emerged from the focus groups was that training was needed. The vast majority of the pastors with whom we spoke have college degrees, and the majority have been to seminary school. However, one pastor eloquently stated, even if you've been to seminary, there's no mental health training in depression treatment. So they identified a huge need of wanting more training to be able to help people in the community. Another theme that emerged very clearly was that partnering is advised as a way to conduct research and to try to provide services. The pastors basically said, Sydney, we like you, but you're not going to just drop in here with your little MD and your little MBA from Columbia and think you're going to do a study and then swoop out. But you have to partner with us. You have to work with us every step of the way for any of this process to have any chance of working. And one pastor who actually has a PhD specifically mentioned Columbia by name. She said, we need Columbia to partner with us, to come to the church to provide these services. And she said, if you come here 2 or 3 days a week, I guarantee we'll fill your patient panel. So there was a need for partnering, the recognition that the clergy needed training, and acknowledgement that stigma is pervasive in the African American community. So we need to figure out how to address that. So after we learned what the pastors wanted and needed, we then wanted to assess what the community's needs were regarding depression. And you'll see in your seats, many of you, the instrument that we actually used. I know there are a lot of students here, so there's not going to be a test. You can relax. But we used a systematic survey called the Patient Health Questionnaire 9. This survey is commonly used in primary care, so if you go to your doctor's office, they may ask you the first 2 questions of this survey. And so we decided to use this survey because it is a screen to identify people who may be at risk for depression, to see if, is it feasible? Is there a need of identifying folks with depression in faith-based settings? So we conducted this survey in 3 different churches in New York City, 1 church in Harlem, 1 in Brooklyn, and 1 in Queens. And we found we were able to recruit a significant number of participants who self-identified as being male, nearly 44%. The average age was 54, and the overwhelming majority were African American. And this shows some of the demographics to show how churches are truly harbingers of engaging all aspects of people across the socioeconomic spectrum. We had positively able to screen 122 people, and you see that we have folks across the income range. We also have people, a pretty highly educated group of folks. Most people were at least high school graduates, and some had college or technical school, and over nearly 90% had at least some health insurance. So the question is, this is the sample. What do you all think? Was depression in the church or no? I see a lot of heads shaking. We found that current depression was extensive. So using that survey that you have in your hands, we found that roughly 20% of the entire sample screened positive for depression. And to give these numbers some context, national surveys have used the same survey, the Patient Health Questionnaire 9, and have found rates of depression anywhere ranging between 6 to 8% of current depression. So we found that in these 3 different churches where we conducted these screenings at health and mental health related programs, roughly 3 times the rates of depression in churches, indicating that there is indeed a need for us to potentially provide services and address depression in faith-based settings. And we're very proud of this study because this was the first time that this type of survey has been disseminated and published in African American churches. And it would not have been possible without specifically partnering with each specific institution. Another key finding was that men, I see a lot of guys in here, which is very encouraging. Men had higher rates of depression than expected. In pretty much every study that we do, women have twice the rates of depression as men. But we found roughly the same percentage of men screened positive for depression as women. So faith-based and other community-based settings could be a great place in which to engage men in mental health services. And because of this finding with men, I was honored to be invited to President Obama's White House Dialogue on Men's Health, where I participated with researchers and physicians all across the country to talk about how can we engage in men's health. And a lot of people wonder, which one are you? I'm the one on the left. So we were invited to the White House to talk about how to engage men in research and to promote health. So given that, we've identified now what the pastors want and need. We've identified the fact that depression is extremely prevalent in these faith-based settings. I was fortunate to get a study funded by the National Institutes of Health to address this issue specifically by partnering with faith-based organizations. And the first aim of that study was actually to create a Columbia-led community partnership and coalition. And we spent a lot of time talking with leaders in the community, meeting with pastors, and our efforts on the ground culminated in this mental health forum, which was held a couple years ago. It's called Community Conversations on Overcoming Stress. We were fortunate to have Elaine McCrae, the New York City First Lady. This is Dr. Gary Belkin on the end, who's the mental health commissioner. We had pastors of churches, we had mental health professionals, and mental health speakers share their stories about how they had experienced depression, how they had got treatment, and how they had overcome it. And this event attracted over 400 people in the basement of a church in Harlem in the summer when it was hot to talk about mental health. And from this forum, we expanded our coalition, which culminated in forming a partnership that we call the Community Coalition on Mental Health. And here's our website. We have representatives from the Department of Health, from Columbia, several different schools at Columbia, from 2 different churches in Harlem, as well as community members to participate on this coalition. And there's a lot of eager, astute faces that I'm detecting in the crowd, and we'd love to have you come hear your voices and participate in the coalition. Our next meeting is actually going to be Thursday, September 28th. So if you're interested in coming to this meeting, please let us know and we'll add you to our listserv. So this is the community coalition that we have created, which formed the leadership structure and the partnership between Columbia and the greater Harlem community to direct all of our studies. So after we created the partnership, we then wanted to select and then empirically investigate a church-based intervention. And after much dialogue and discourse, the intervention that we selected is called mental health first aid. Now, mental health first aid is an evidence-based intervention. That means that there have been numerous studies, including large studies that have examined the studies that show the effectiveness of mental health first aid at reducing stigma and increasing people's knowledge and being able to recognize someone with a mental health problem. And mental health first aid teaches people the signs and symptoms of common mental health problems. So after taking a mental health first aid course, you would know what are the symptoms of depression, or what does it look like if somebody is drinking too much alcohol, or what if someone is at risk for suicide, or what does a panic attack look like? So mental health first aid equips you with those skills. Importantly, it connects you and gives you the skills to be able to connect people to support so that they can get the help that they need. Now, this is for the students and the parents and everyone in the room, but mental health first aid is taught for adults as well as adults who work with youth. So a big part of what's happening now is that we're trying to teach teachers mental health first aid so that they can work with students, because there's a lot of stress being a student now. I didn't have to deal with social media, but you all do. And so we have mental health first aid for both adults and youth. And it's also available in English and in Spanish. So we really want to be able to use this intervention to be able to reach the broader community. So again, mental health first aid gives the tools to help. Who in here has taken a CPR course? Okay, so in CPR, this is a test. What does the ABC stand for? Airway, breathing, circulation. So if something goes wrong, this brother I'm going to go to. Everybody else in here, I don't know if they really passed the CPR course. But exactly, airway, breathing, circulation. That's the mnemonic for mental health, for CPR. Those are the three things that you learn in a CPR course. You're not taught how to be a heart surgeon, but you're taught how to help someone get connected to an ambulance or to the hospital so that professionals can take over. And that's exactly what mental health first aid does. It gives you the tools to help someone who's experiencing a mental health crisis until they can get connected to the appropriate professional help. So it allows you to assess for risk of suicide or harm. It teaches people to listen non-judgmentally, to be able to confront some of the issues and the words and the negative associations that we brought up earlier that were talked about when we talked about stigma. It encourages people to give reassurance and information on how can you talk to someone who's experiencing a mental health problem, or how can you reassure yourself if you're having a mental health problem. And it teaches people to seek and encourage the appropriate professional help. And it teaches people to encourage self-support and other help strategies. So this is the mnemonic for mental health first aid, and there will be a quiz on this at the end of the talk today. So if you're interested in mental health first aid and signing up for our courses, we would love for you to participate. At the end of our time together, Ms. Emily Santiago and Ivy Harris will be at the basement downstairs and signing people up to participate in mental health first aid studies. And if you can't participate in one of our trainings, the Department of Health is offering mental health first aid courses all throughout the city. So we'll be happy to connect you with them as well. So now to the science. So now you know what mental health first aid is. We wanted to make sure that we're rigorously evaluating its effectiveness. And so we're asking people after they take the course, has their knowledge improved? Are they able to recognize someone who maybe has depression or schizophrenia? Has their confidence in providing help been increased? And has their attitudes or stigma changed? And also we want to know if people's functioning, we talked earlier about how impairing depression can be. Has their functioning improved? We're also collecting stories about how people who take mental health first aid use it or how it impacts them. I've heard several people who've taken our course who said that there was someone in their apartment, a neighbor in their building, or someone on their block who, after taking the course, noticed they wouldn't dress up like they normally would. Or maybe they were a New York Knicks fan and they wouldn't get excited when the Knicks finally won a game. So they were able to notice the signs and symptoms of depression after taking the course and maybe encourage that person to seek professional help. So those are the stories that we're collecting. And we do our evaluations at 3 different points. before they take the training, immediately after, and then 3 months later. And so far, we've trained 93 community members at one of our local churches, and we actually have 2 church study sites. So this is the evaluation, the scientific aspect of the mental health first aid training that we're doing. So the last aspect of my grant is to try to expand access to services. And I'm very fortunate to be partnering with one of the churches that we're working with on this grant. Last December, actually opened a mental health clinic, a free mental health clinic affiliated with the church. This is 1 Corinthians Baptist Church, opened up a center called the Hope Center. And I'd like just to take a little bit of time to tell you a little bit about what the Hope Center does.
People don't want to be labeled as crazy. And then from the church's perspective, you always heard the whole notion of, well, there's some things you battle with, well, you can pray it away. If you pray and seek spiritual guidance, these things will go away. And I don't believe that. Offer individual counseling, group counseling. There'll be workshops and seminars. We look at them as innovators, not persons who have issues, not clients who are wrestling with some kind of disease, but innovators who are finding creative ways and creative paths to their own wellness. You no longer have to suffer in silence. We want to take that stigma off, and that we want to create paths of wholeness for people who battle in silence with mental illness.
All right. So now you see why I'm so excited about the Hope Center and expanding access to services. And as an aside, the executive director of this clinic, Reverend Kendra Frazier, is actually an alum of the Columbia School of Social Work. So that's another way that Columbia is providing services in the community. I'm very honored to be a part of the Community Wellness Center at the Brain and Behavior Institute, where we're actually expanding implementation and evaluation of mental health first aid to West Harlem. And that's why it's so important that we're able to provide courses in English and in Spanish. I tell people that hablo un poquito español, pero aprendiendo. Did I say that right? So I'm learning. So our hope is that we will be able to expand these services through the generous leadership of the Zuckerman Mind, Brain, and Behavior Institute to as many people as possible in West Harlem, and importantly, evaluate whether or not it's having the impact that we hope it is. We've been very fortunate to be approached by the Department of Health to actually identify other faith-based organizations, including mosques and synagogues, with whom we can partner and try to provide mental health services. This is a diagram of all the faith-based organizations that we've identified in Central Harlem, and we're going to expand it to West Harlem so that we can have a hub through the Hope Center of providing faith-based mental health services through Harlem, and we want to expand it to all of New York City. And as we are nearly at the end of our time together, I'd like to share with you my vision of how together we can remove some of the stigma associated with depression, get people hope in the care that they need. So as I close our time together, let us ask ourselves, what will be the news story of Columbia University in Harlem as it relates to mental health? Will it be one of neglected opportunities and people continuing to suffer in silence? Will it be one of when people talk about mental health problems, there's a holy hush in the audience? Or will it be one of the journey that I had to make when I was a third year in medical school, rising into my fourth year, and when I struggled mightily with my coursework, when I was struggling in my romantic relationship, and when I started sleeping 12 and 13 hours a day, when I gained 20 pounds, and on the day that should have been the happiest day of my life, when I got my medical degree, I was shrouded in a cloud of despair. And I had to come to grips with the fact that I was clinically depressed. And I went and saw a therapist. And I still see a therapist every single week. I actually see her tomorrow at 5:30 p.m. So this can be the story that we create. Perhaps you know someone in your family or in your school who's struggling with thoughts of, is life worth living? Perhaps you have a neighbor or someone on your block who, you think it's fun and games to see them shaking after that morning beer, but this is a serious issue. I challenge all of us to think about what is going to be your role as we rewrite this story of Columbia and Harlem as it relates to mental health. Thank you.
So if there are questions, I would encourage everybody to stand up and wait in line at the microphone.
Thank you, Dr. Hankerson. I don't need a mic. Thank you, Dr. Hankerson. I think this was an excellent presentation. As a clinician myself, as a psychotherapist, one of the saddest things I've come across is an 8-year-old boy who has thoughts of killing himself. And his parent, as she sits in the room with me, often says, Steve, is this something he can overcome? Like, what's going to happen here? So my question for you is, do you think that depression is something that can be overcome or just more so managed throughout someone's life?
That's a great question. So the question was, is depression something that can be overcome or just managed? I think this notion of overcoming is something that's very pervasive among people, especially in communities of color and often in faith-based settings. The notion that you can just pray your way through a problem, you just push harder or work harder. I think it's very important for us to realize that depression is a chronic illness, just like diabetes or just like high blood pressure, and it must be managed. That management can look very different. For some people, that management can look like therapy. For some people, that management can look like exercise or yoga. For some people, that management can look like increasing your social support. And for some people, that management means taking medications or the combination of all of those things. So I think it's very important to realize that depression is a chronic illness that does need to be managed.
Has your research or will further research also include subgroups within the African American community, such as young males who identify as homosexual or transgender and their relationship with depression?
That's a great question. So the question is about first of all, is everybody here? I don't want to repeat if everybody can hear the question. No. So the question was about, will our research identify males who identify as homosexual and transgender and how depression relates to them? Is that correct?
Indeed.
Okay. Great question. So Reverend Kendra Frazier, and she would not mind me sharing this because she shares it from the pulpit. Reverend Frazier, who is the executive director of the Hope Center at 1 Corinthians Baptist Church, is openly gay. And so one of the things that we have talked at length about is how are we going to address issues around sexuality and gender and incorporate that into our research, because issues around homosexuality bring up its own stigma in faith-based settings. So that is something that we're actively looking at. We're also looking at all aspects of the African diaspora. We've had a lot of kind of internal struggles about how do we ask people to fill out the question about race, as well as where are people originally from. So we're absolutely addressing that issue. Yeah.
Good evening. Thank you so much for creating the space and the grace to share your wisdom. So really quickly, I don't have a question. I actually want to know how I can partner up with you. I was diagnosed with depression at the age of 15 and anxiety at the age of 23. So I manage very well. I'm currently a wellness advocate and also a mental health podcast host. So I definitely like to create space, and I'm also mental health first aid certified as well.
Oh, awesome.
So I definitely love to support people that are experiencing depression and anxiety and any other mental health issues, and really like support them in taking the steps to see therapy, because in people of color community is something that we don't have access to, well, limited access, and it's just still that topic that is hard to talk about.
Yeah.
So I'm just here to say thank you, and I would love to speak to you at the end. I would love to partner up.
Thank you so much for sharing your story. I think that took a tremendous amount of courage for you to do that in this forum, so thank you for that. For anyone, yourself included, who would like to partner or work with us, please see myself or Emily Santiago and Ivy Harris, who's over there, and we'll be happy to add you to our listserv. Thank you.
Thanks, Sydney. How is outreach being done to folks who aren't necessarily connected to a church?
Great question. So how is outreach being done for people who are not currently connected to a church? So right now our focus is on churches and faith-based work. However, I did get a grant where we're actually going out into the community to conduct more focus groups and interviews with barbers and in other community-based organizations and schools to identify how we can identify and connect with people that are not in the church. You know, a barber is like a pastor in many respects, because you get in that barber chair and you share so much. My chair is much less now since my hairline is receding a little bit. So I don't have as much to share with my barber, but that's the avenue that we're taking to get people who are not connected.
Good evening. I'm a public health nurse with the Department of Health, and I work with first-time moms. I have a question and also a frustration with referring a lot of mothers who you do the PHQ-9, you do the assessment, and you refer them, and the places are not there, or we don't have a network or a liaison to to help them and direct them into the places once they finally acknowledge that they need help. So a lot of times we refer them and there's no place for them to go.
Yeah.
Or they tell them, oh, call back in 2 months, call back in 3 months. Once you get that person in that directive, it's very frustrating for them and us as nurses to encounter this often. So we don't have a liaison to help them to go from one step to the next.
Yeah.
So that's one of my frustrations. But my question is there going to be some kind of development also for those who don't have health care?
Yeah.
And they recognize these things, and there's not enough free centers for them to go to in order to get the health care, especially the ones who are after 26 years old, who
Right.
don't have a profession, and they won't be having a place to be able to go to get health care.
So thank you for your question. It was two parts, and I just
Yeah,
briefly
that's
will summarize it. So one was more a statement expressing your frustration with this issue around lack of access. You identify someone who's depressed but doesn't have anywhere to go. So that's part. The third part of the study is my goal is to try to increase access to services in partnership with these faith-based organizations. The issue about insurance is actually an example of how myself and Dr. Williams, who's at the Wellness Center, are going to be working synergistically. he has a community health worker program where he is training people from the community to be community health workers, where they can go into the community and get people connected to insurance so that they can then have access to services. So if you're interested in providing us your information, I'd be happy to share Dr. Williams' information with you so that you can be connected to that community health worker program.
Thank you very much.
Hello, thank you very much for your presentation and for all of the work that you're doing. I have a question. You mentioned, and we talked a lot about the stigmatization of mental health disease, but I wonder, do you find that there is a difference in the acceptance of the definition of depression and other mental health problems as diseases in terms of their clinical definitions? Do you find that there's a particular resistance to the definition in African American communities? Is there also a disparity there? And if so, why might that be? And do you think that interacts with these other problems?
So the question is, do I think that there's part of the stigma associated with depression is connected to the label of being labeled clinically with depression in the African American community? I think that is true for all people. I think many people don't want to be labeled with being depressed or don't want to be labeled as having bipolar disorder or whatever the case may be. So I think that issue of labeling is pervasive for many, many people, regardless of race and ethnicity.
Just for clarity, I mean the acceptance of it as a definition, as a clinical disease. I mean, is there any difference there as well? I mean, I see that it's stigmatized for everyone, but are there any differences in the acceptance of it as a clinical disease?
I don't know any data per se on that, so I'm not sure.
Fair enough.
Yeah.
Thank you very much.
Yeah, no problem.
Hi, hello. I'm here actually an exchange scholar from Indonesia. So my organization providing information and counseling for safe abortion in Indonesia. So every day we receive about 50 calls, 100 calls from women, and all these women in stress or sometimes depression as well. So the counselor job is to take care of the woman, but my job is to take care of the counselor. What I'd like to ask to you is that do you have any resources, information, or platform on how to take care counselor or social worker, preventing them from burnout or depression? Because when you work on this every single day, it becomes very normal to you, and you don't realize that you become burnout.
So the issue is, do I have any resources on how to provide help for counselors or social workers from getting burnout in this work, which is a huge issue. So I'm happy to provide some of those resources. We'll get your information and be happy to distribute that to you. I think for folks who are in the mental health field in particular, I think it's so important that you find at least do three things. One is find self-care. So whatever that looks like for you, whether that's exercise, friends, going to the movie. I like fishing and cooking. Self-care. Two, I think for some point it's important to have a therapist to help you process those own kind of issues. And three, it's important to have a social support network who can support you through those things.
Thank you so much.
Hi. I'm here to invite you to partner and for me to partner with you and join in the research that I've done. An axiomatic problem that I see with the presentation is that while you're offering first aid, you can't solve the problem. You don't know how to solve the problem. And the reason that you don't know how to solve the problem is that you don't understand the human mind. You don't understand subconscious processing, right? Semi-conscious processing, conscious processing. I understand also that there have been incredible inhibitors to you engaging in understanding that process because as scientists, you're dealing with human beings. So you can't put them under like they did in that Tuskegee study. What I offer you is a way to step over all of that testing on human beings and to provide you with the answers that you need on how subconscious processing operates, semi-conscious, conscious processing, how to find the architecture of depression in order to solve it and to prevent it from coming back. I gave your assistant my number. I have cured a suicidal paranoid schizophrenic. And one of the things that you are offering here that I completely, in the deepest parts of my heart, agree with, is your partnering with the religious community. Because what I have found in my 30 years of research is that you can't solve mental health issues without sound religion. My schizophrenic that I solved, that I cured, he got in the tub and slashed his wrists because the voice of the dragon told him that because he drank a cup of juice, God was mad at him and he had to kill himself. And the voices were driving him as he slashed his wrists.
Thank you for your perspective.
Okay.
And I'm glad that you gave Emily your contact information.
Okay.
And we'll be happy to reach out with you. I think
All
in
right.
the interest of time, I want to
Okay.
let other people speak, but I certainly want to address your comment. So you brought up the point that it's important, from what I gathered, is that it's important to address the
You have to have God, is what I was saying, yes.
Thank you. That it's important to address the subconscious, and it's important to acknowledge some of those aspects. I think that's one of the cool things of community work, is that it's great to hear a bunch of different perspectives, and so that's why we encourage everyone to share your perspectives with us as we continue this work.
First of all, I'd like to thank you for your presentation and for the work that you've been doing. I'm currently a law student at Columbia. I've been particularly interested in mental health law going forward. And one of the things I've been looking at and talking to people about is all the different intersections and interdisciplinary work to resolve mental health issues and also stigma. And I think it's great to have a partnership with the churches because the community aspect's very important. And you also mentioned going out into the community to help connect people with insurance. I was wondering if you have also been looking at the perspective of, I guess, some of the other aspects that influence, whether that be helping people get support with housing or, more than insurance, also, disability benefits or Social Security, and if not, if that's something that you've been looking to go forward with.
Absolutely. So the question is, have we looked at some of the other social factors that kind of contribute to disparities, whether it's income, housing, that kind of thing? Yes, and we've actually, part of our coalition is an organization called New York Lawyers for the Public Interest, which I think you'd be very interested in. And they look at that very issue. They look at health justice and disability justice and economic justice. So they make sure that people can address those social factors that contribute to health disparities, such as housing inequality and income inequality. We'd love to have you, give us your contact information.
Absolutely. Thank you.
Hello.
Hi.
I'm a high school student. I attend University Heights High School, and I have kind of like a two-part question. So my first question is your organization only open to the Harlem community? And the second question is, I am a student, and I do attend school, and I have a lot of stress because I take a lot of classes and courses, and I even take college courses. But I wanted to know what age group is this open to? Like, is it limited, or is it only open to like adults?
Right. It's a great question. So how old are you?
I'm 16 years old.
You are 16. Well, thank you for standing up and asking that question. Right now, because this is part of a research study, to be a part of our coalition, people have to be 18 years or older. However, we have a lot of community forums and workshops that take volunteers in which youth can come and participate. So if you're interested in, again, joining our coalition and getting our information so that you can attend some of those events, we'd be more than happy to have you come.
Thank you.
Yeah.
Thank you so much, Dr. Hankerson, for sharing this with us. I was just wondering something with the vision that you mentioned regarding kind of going forward, and specifically the Hope Center.
Yeah.
I was wondering if you can comment on the sustainability of it and maybe challenges that you had going forward. Do you see this as kind of a model that other churches should follow?
Great question. So the question is about the sustainability of a faith-based or church-based mental health clinic. That's a huge issue. The clinic that Elizabeth Davis worked in actually closed in 1959 due to three main issues. One was lack of funding from the government. Two was the leadership, the pastor changed. And three was staff kind of fell off and went to different places. So I think as we are in the process of getting this contract from the city, we are very fortunate to already be addressing one of those issues, which is government funding. We hope to get other sources of funding to address that, and then leverage that to bring on more staff so that we can really create something that's sustainable. But that's going to be the main challenge going forward.
Thank you.
Hi, so a disproportionate number of African Americans are incarcerated. Are there opportunities to provide services to these individuals through existing faith-based or church programs?
That's a great question. So yes, there are a disproportionate number of African Americans who are incarcerated, and there are several churches that actually specialize in working with people who are incarcerated. One particular house of worship I know of is in Brooklyn, actually provides screens in the church so that children through Skype and other technology can have weekly visits with their parent who's incarcerated. There are also programs in which churches provide social services and job re-entry programs for people who are incarcerated. So there is a lot of work that's being done for people who are incarcerated.
Thank you.
Hi, good afternoon. Thank you very much for all you do. I'm part of the statement and part of a question, and I have a little bit in the mental health, and one of the issues that caught my attention is that all too often we don't look at the rights that mental health patients have, and somehow they seem to be written by those who are non-mental health patients for mental health patients. And going in line with a question I heard before regarding the legal aspect of this, is how this addresses the number of disparities in mental health care that we're trying to address at this moment. Would you happen to have any comment on that?
I'm not sure I understand the question.
Regarding the legal ramifications stemming from not treating a mental health patient as a human being.
Well, so the question is the legal ramifications of treating someone who has a mental health problem. I know that there are a lot of advocacy groups who provide support and services for people who have mental health problems. A big part of what we're doing in partnering with the Department of Health is making sure that we have someone always represented at our coalition meetings from the Office of Consumer Affairs, so that there's always at our meeting someone with lived experience who has sought mental health treatment in one of the community mental health clinics in New York, so that they can be the voice for people that are actually seeking services. So that's the way that we've gone about addressing that issue.
Good. Thank you. Thank you.
Hi. Thank you very much for a great presentation. My name is Lawrence Harding, and I represent and I'm the director of a community-based program here in Harlem for people with physical disabilities. And most of our population has either traumatic injuries or congenital injuries, and most of them are wheelchair users. And based on your project at the Hope Center and working with one of the members here, Azalea Mallory, we're in the process of creating a mental health wellness program for people with disability. And I'm wondering to what extent in your research you had not only the issue of race and access issues, but also the physical limitations of access that injury and disability, physical disability, bring to this problem of mental wellness. And to what extent did your research of the subjects bring the physical limitations in as part of the construct of their depression?
So the question is, to what degree have we looked at or examined the physical limitations of some of the clinics and providing services for people. First of all, let me say thank you so much for you all being here and for bringing this issue to light. It's one that's so important and one that's very dear to my heart. I actually have a family member who has cerebral palsy, so I'm very passionate and sensitive to issues around people with physical disabilities. We have not explicitly looked at or examined issues around access in the mental health care system in general for folks with disabilities. However, at every event that we have, we make sure that we do have it at buildings that are wheelchair accessible. And we always reach out to coalition members and people in the community to try to identify how we can make our meetings and our spaces more receptive and more inviting and just easier to navigate and get around for folks with disabilities. So you bring up a great point, and we'd love to hear your perspectives about how we can make that better. Thank you.
Thank you.
Hi, thank you for your presentation. It was great. I really enjoyed it. My question is basically if you have any advice on patient adherence. I work for YAI, and mental health is one of our major services, and one of the biggest barriers to treatment is actually patients not coming into therapy. So if you have any advice on how to, approach that, then I would appreciate
So the question is about adherence and how do we try to increase people for coming into their appointments. That's a tough question. I think there can be a lot of different reasons that people don't necessarily go to their appointments. So I think the most important thing is for that person and their family to develop a really good relationship with that particular provider. And if there are issues that they have with that provider, for them to be able to talk about it and address it so that they can kind of overcome those and try to increase compliance.
I want to thank two groups this evening. The first is Sydney for giving us a fantastic presentation, and you can tell by the list or the long line of questioners that this was, you really touched our hearts.
Oh, thank you.
And that's good. And then I also want to thank the Stavros Niarchos Foundation for making all of this possible. So thank you both to Sydney and to the Niarchos Foundation for everything that you've done.
Thank you all. And thank you again, Tom, for this opportunity, and to the Niarchos Foundation for providing Columbia scholars the opportunity to do this. I don't know where my presentation went, but I do want to announce to everyone that on November 1st, that is when the next Niarchos presentation, the lecture will be. The presenter is Dr. Joanna Steinglass. Her office is right around the corner from my office at the Psychiatric Institute. She's going to give a very riveting and entertaining presentation about eating disorders. So if there are any questions about eating disorders, please feel free to come out to that talk on November 1st. And lastly, in conclusion, if you're interested in taking a mental health first aid course, either through our study or anywhere throughout the city, I truly believe that it can transform lives, because I do believe that it increases knowledge, it reduces stigma, and it helps people get help. Emily Santiago will be downstairs signing people up, and I welcome people to come talk to me for other questions. Thank you.